So those sutures determine how much you rotate the leaflet, right?
Yeah.
How do you decide?
So usually we start here, the same position where we.
Okay, so this is important because now you have sort of basic of the cone, and then you start, I would say, reimplant or resecuring to the true annulus. So the first stage is the 11 o'clock where you started this delamination process, and she mentioned that they never rotate this area. So this one is detached, but they're going back to the exactly same area. So what I found that, so she's going to kind of, put that stitch and then start putting that. But, somebody like, us who doesn't do a cone every single week, this process is actually quite difficult. So I usually place a couple of sutures to place the cone in a proper position and move around. Then actually secure to the annulus. Go ahead.
What if one does a partial the vagus that will reduce the annulus size without kinking the right coronary artery?
And that's a question. So the sure, yeah. So yeah, that's a great question. So this is a way to reduce the annulus size. I think Dr. Da Silva's group and Dr. Deran's group use a similar techniques to
Increase the size.
reduce the size of this atrialized portion and kind of posterior inferior annulus all together. So this is very convenient to have this one suture line coming up from the atrial portion all the way up to the annulus. Then to avoid this kinking of the right coronary, you can have a couple of different ways to do that. So there, so this model they couldn't demonstrate very well, but to reduce the annulus in this particular area, they place much smaller sutures, and then they suture towards the inside as opposed to going outside to move away from the right coronary artery.
You can decrease more than here. That the tissue needs to move like this.
Yeah, that's right.
Right? This area. Decrease the end here and here.
So this is, I would say, it's a really experienced surgeon she is.
Yes,
So she just put in sutures and then tie it. So she kind of know where this valve has to sit. But if you don't do a lot of cone, you can put a sutures, but they're not tying it so that you can adjust. The things that often happen to me is that if you place a couple of sutures and look at it, and in one area you have a lot of redundant leaflet, and in other areas have a deficient sort of excursion, then you can adjust to make it even. But she's doing it as she goes, as she's very experienced.
Yeah, yeah. And this is a free leaflet also. So here we usually switch to the end. Here there's a lot of redundant tissue.
Now you can see this, that the cone is pretty much done. So you have a couple of corners secured, and then you just have to fill the gap by suturing the leaflet to the annulus.
I find that there is no respect of the orientation of septal leaflet. Just the tissue is used in any orientation, correct?
That is so correct.
You lock
Yeah,
it
it just had to fill the gap. So that is why that's the exact area they frequently place the fresh pericardial patch to fill if septal leaflet is not enough. So I was surprised that they use the pericardial patch in 40% of the patient. So that's a lot than I anticipated.
The model is good.
Pericardial patch is autologous, right?
Yeah, pericardial patch, fresh autologous pericardial patch. Gani?
Yeah, one of the concerns I have, obviously, that portion of the posterior leaflet and septal, if there is adequate septal, is a bit of saddle shape like Dr. Yu showed us. You have more mobility on the posterior leaflet, but how do you adjust the linear height? Because you're lifting it up from where it came to the true annulus, right? So at what point do you decide you need to add tissue or there's enough?
Yeah, so I think the ideal cone is that you have this excursion and all around like 360. Oftentimes you can get that in this septal posterior area, but if it's really deficient and it doesn't come up, then that's when probably you should add. And maybe you can run it. The one thing that they do and we do as well is that to avoid the conduction system, we run this part of the leaflet from septal leaflet to the posterior leaflet on a tendon of Todaro. So that means your cone is little tilted upwards. So that means that you actually need more leaflet tissue on that area, which is deficient in the beginning. So that's why some cone actually need a patch. So this is, you can probably stop there. So this is the area that she's reconstructing the area of septal leaflet, and to avoid the conduction, the suture line on the annulus is not a true annulus, but on a tendon of Todaro. And when she's suturing from the sort of septal anterior commissure all the way down to the coronary sinus. She saw along the coronary sinus, in medial wall of coronary sinus to avoid the conduction. So this is exactly same as cone reconstruction and stance operation. So that's how they and we both avoid the conduction.
Slowly, so I followed it and I cut it, and then I could find the coronary signs, and then the vein. Yes, there was also stenosis of the coronary signs that was not diagnosed. Here, before we suture, we usually do the CTI line of ablation. Okay. So usually we do opening. Yeah, that's right. Because then you have all the line B, and then that's so this.
Okay, then this is another thing that we don't usually do, but the Dr. Da Silva's group have a lot of experience on this intraoperative cryoablation, the prophylactic cryoablation. So you can see the two lines. So hopefully you can probably run it with a marking pen. So one line is from the mass of the inferior vena cava towards the trachea valve annulus. And also they have a small line from the inferior vena cava to the end of the right aortotomy incision. So that's how they kind of did an isthmus ablation to make sure there's no reentry tachycardia. They said if it's not baby, they do this cryoablation routinely.
Many times when you have battered stays in the fenestrations.
Yeah, for example.
In the here. and placate the leaflet in the other direction. Okay? This is what we usually do. Usually we do this patch, like in this situation. Now this is 6, so here I think we can close a little bit more. I don't know the info holder. This one is better.
The other question is, when you complete the cone and it's still regurgitant, this operation doesn't have a lot of options.
So
Right.
yeah, so what the cause of I will show when I finish here.
Yeah.
We will evaluate. But usually the cause of the regurgitation, if you have enough deep leaflets, usually it's because there is some papillary muscle holding, preventing the excursion of the valve. Then we need to make a decision if we can dissect more or if we need to translocate the papillary muscle.
I see.
And even like if you don't have a papillary muscle, you can create some quarter to improve Gore-Tex.
So here, frequent asked question is that whether this suture line has to be single or double. The experienced surgeon like Luciana's, they never double the suture lines, but we always do. The other thing for adolescents and adults is whether or not we use artificial valve ring to reinforce. They never do that. We do. Make sure this suture line is secured, but they never use the artificial ring.
Artificial cord,
One suture line.
one suture. Ends, it's okay, but it needs to grow.
Yeah.
PDS, the prolink the PDS.
And what about?
You don't need a ring. So here, remember that but some patients unite here, then the linear distal attachment. Sometimes you can see
Laminated to the fat layer.
so you need to.
So that's fenestration that you have to create. So obviously, if you make big fenestration.
Yes, just the.
You have any time that when delaminate.
So you do this at the very end, just find a hole and then close it?
Yes. Sometimes when I'm delaminating the valve and I saw the orifice there, I just close it immediately to not forget to take. So
that's kind of sort of a general sequence of cone operation. There's a couple of things that I learned today from Luciana's comment. Obviously there's a lot of fenestrations on the leaflet that you must close, and then so she does it at the very end, or when she's delaminating the leaflet, and then there's an obvious fenestration, she closes as she goes. The other thing that she's really looking now after she create the cone is whether or not this inflow into the outer tract is adequate size. So she often make the fenestration on the anterior leaflet if it's dense and not opening to create more opening. And the importance is that those fenestration that's meant to create more flow into the outer tract should be at the bottom 1/3 of the cone, and then not higher than that, because higher you make the fenestration more chance to have a regurgitation. As June mentioned, she measured this inflow with 2 fingers. I'm not sure how accurate that is, but okay. So we have questions. Do we always detach the whole valve to construct the cone, or leave the part of the anterior leaflet attached annulus from 8 to 11 o'clock? Yeah, so that is a great question. I almost always leave this small attachment of the anterior leaflet by, I would say, 9 o'clock or so, and then try to attach the septal leaflet to that area. So in this demonstration, Luciana actually detached everything. And in her views, as long as there's a good papillary muscle structure to support the anterior leaflet, you don't need to keep that attachment around that area. You're gonna sew back anyway, and maybe that make creation of comb easier. The other question we have on the chat is, could you please try to show again where are you putting the suture line to avoid the conduction system? Okay, we can probably go back to the So, so this is the area that Lucian actually saw half of. Can you go back a little bit? So we're talking about septal leaflet. Okay, so that's perfect. So she just starts sewing the septal leaflet onto the tendon todaro from, if it's normal tragus valve, from the anterior septal commissure towards posterior to the coronary sinus. So this is where the cone is tilted upwards to avoid the conduction. Can you run this?
Basically, that means that you have a suture above the AV node.
Correct. Yeah, everything happens above the AV node. So hopefully that makes sense to the audience as well. As I said, this is a very common way to avoid conduction in a stance for operation as well as cones. One thing that Luciana sometimes do is to make a couple of interrupted sutures along the suture line to avoid the compression of the conduction by having this continuous suture line. So they're quite careful, even though they're quite above from the conduction. Okay. Yeah, we can stop. Any question or comment from the audience?
So it's not the surgical question, but I was afraid of it. It really stated about that. But you disconnect the valve leaflet from the body of the heart. And then how do you expect future growth with the patient's growth? If it's adult, it's different. But however, let's say 3 years of age and 4 years of age, you do the cone. And then do you expect a proportional growth to the body growth?
Yeah, great question. I don't know, but not many patients actually come back for reoperation. That just means that your leaflet's actually growing. You know, it's similar questions asked when we put a artificial cordae for infant mitral valve, and if they have a good ARI outcome, they tend not to come back for reoperation, although this Gore-Tex cordae never grow. So this one's all native tissue. Even though you disconnect it, you're gonna put back in. So there must be some blood supply. Yeah. The one thing, you know, obviously Dr. Da Silva's group never put an artificial ring to reinforce. But for us, for the growing child who need a cone operation, we never put a rigid ring so that annulus have a growth potential. But to answer your question, I think cone will grow. It should grow.
Our patient population becoming younger and younger, and then we might have a kind of serial follow-up to assess the growth during growing of the body.
That's right. So, I mean, this consensus guideline said for the asymptomatic patient, it's 3 to 5 years, that's preschool age to do the cone. And Dr. Da Silva is doing actually much younger patient, younger age, like 1 year plus. So those cones would be very, very small compared to other size cones. So it must have a growth potential.
I was going to say that you never disrupt the bottom end of the valve. So the distal end of the leaflets, chordae, and the papillar muscle attachments are all native. So perhaps that's where the growth comes from. And imagine with the distension of the RV, which is never quite normal, you probably have enough distension of the annulus that it keeps up with somatic growth.
Yeah, I think so. Yeah, the caudal structure have a potential to grow. Also, the leaflet part should stretch or expand. I'm not sure that's called growth or not, but yeah, I think that's right. That reminds me one important point. As I said, the Dr. Da Silva's group place the pericardial patch in 40% of the patient. I vaguely remember Dr. Derani mentioned that he puts the pericardial patch in sort of 20 to 30% of the patients. So anyway, so they have pericardial patch, and obviously those pericardial patch can calcify and it can compromise. So for that reason, so both of those expert group, they never put the patch at the bottom of the cone. So it's always has to be the top of the cone where it's the effect of calcified or stiff leaflet is minimum, and then still have excursion at the main part of the cone, which is kind of middle part. Okay. Yeah.
So can I take the freedom to ask the Francesco and Brandon, would you mind standing? So this model is that first time in the world. Although that I have done this one for a long time, I haven't expected that we are able to produce such a nice, really model for surgical planning. And then Luciana and Jose, both the da Silvas, really appreciated the quality of the model you guys made. And then Israel led that is, I would congratulate the three of you.
Thanks, Isra. Thanks, June.
Thank you to you.
All right. You wanna do the okay? So this is kind of the end of offshore part of the symposium. Thank you for listening in for 2 days. I think we have a lot of both important, interesting, and informative sessions. So we have a in fact, I haven't had a chance to make a slides for the summaries, but I can summarize this kind of surgical part of the discussion. So obviously, there's two important consensus guideline was published last year and this year, and one of our key speakers, Dr. Konstantinov, he was leading this consensus guideline, and I was quite reassured to read those guidelines because we're not doing anything wrong or anything different. Particularly the management of severe Ebstein's in the neonate. They actually use our guideline sort of flow chart for sick neonate in their guidelines, and so in terms of triaging the patient going for stance or non-stance approach, so we've been consistent with guideline, and the patient, the COM procedure for asymptomatic patients. So that's something that we kind of have to rethink about the timing of COM procedure, because we tend to wait a bit longer until they become either symptomatic or having more progressive right ventricular dilatation, cyanosis, and so on. But sounds like the fields are moving towards more elective, prophylactic, elective operations.
Agree. I think some of my reflections, it matches a bit of the rest of the field, right? Once we've overcome the sequelae to a certain extent of bypass and we're able to do these complex neonatal surgeries, then you realize that although the patients can be incredibly sick at these severe spectrums, getting them addressed early only helps to support them in the longer term, which also was nice to see matched in the neurodevelopmental outcomes that you showed, Dr. Seed, in that, understanding the patient as best as you can in advance. So all the fetal advancements in diagnosis, the ability to counsel carefully on the spectrum of disease that you have, the preparedness for the really sick extreme case so that the team can be mobilized rapidly as needed, so that you're not spending too much time trying to reinvent the wheel or think through what maybe should be done. And you can kind of go on a pathway towards, let's get to a good hemodynamic state with surgical intervention early so that we can get those patients recovered to the best that we can. And for those on the lesser end of the spectrum, then, and even in later life, you're sort of in the same standing. Maybe we do need to intervene earlier now that we're better at intervening and modifying the sequelae of intervening so that you prevent the sequelae of prolonged chronic disease.
Yeah, and I found the conference to be very educational in terms of understanding how far we've come with this lesion that was really, you know, fatal until relatively recently. And so efforts in terms of the fetal management and then the introduction of exclusion of the right ventricle really improved that. And I think the other thing for me was this revelation that you're not committing the patient to a Fontan circulation for life. You actually, you're using that exclusion of the right ventricle just to get them through that initial period when they're not going to tolerate all that TR they still have a underdeveloped pulmonary circulation, which isn't going to work with the right ventricle. And so, but you've still got a chance to get back to a biventricular circulation, especially now that we'd be more careful to preserve the valve, think about the pulmonary valve function in the future. So that's very exciting, although, you know, sounds slightly too good to be true. And I think that probably the next phase is going to be learning about how to manage those right ventricles as we bring them back into the circulation. I suspect, you know, that it still will be challenging at times. So
I think we'll have patients surviving that we hadn't previously had surviving, which is always an additional learning curve.
Yeah, I just want to comment on that biventricular conversion. Lindsay, you'll come next. You can have a little comments on that. But well, so this again, come back to this consensus statement, which quite detailed. You know, how we do the biventricular conversion after the stents. But in fact, we actually don't have a lot of data. So I'm quite surprised that they have quite detailed ways to. Even Dr. Da Silva's group did 15 or 16, whatever number. And so we actually don't know what the consequences of, you know, those right ventricle as a 1 1/2 or full biventricular repair. So we only done 2. They're surviving, but I think we should keep watching our patient and also what other groups are doing. Lindsay, you want to comment?
Thanks, Osami. No, I agree with what about everything that's been said. I think the other challenge, whether or not it's a Starnes takedown to BiV, or even just the patients that get the semi-elective cone repairs in the toddler years or later in life, we still see a lot of long-standing postoperative right ventricular dysfunction. And we really don't have any real good treatments for right ventricular dysfunction in the long term. And I think that in addition to dealing with the valve disease, many patients with Ebstein's also have this right ventricular myopathy. And so I know that there's lots of efforts to work on investigating some of the heart failure drugs that we use for the left heart and the right heart in the adult congenital population, for example. And I think some of that work will likely play into how we manage some of these children and adults over the long term too.
And just in relation to that, I saw an interesting editorial written by Joe Durrani, you know, emphasizing that, you know, things like regenerative therapies stem cell technology and so on might be of interest in that setting.
I think the other emphasis that came through in all of the talks is just the need, like many of the other diseases, for this very comprehensive total body system, holistic view of what the patient's going to need, particularly in the most severe range, so that you can coordinate and work collaboratively to really improve outcomes on all fronts, not just a good repair, but the entire patient and including the patient family growth and development.
And the need for us to collaborate across our specialty, across different centres, because of this being such a rare condition that it's hard to learn a lot about it when you're just in one centre. And so thanks to everybody for joining, and we will be putting all of this material onto YouTube, onto the Congenital Heart Academy website. That usually takes us a few weeks to edit everything and get it loaded up, but it'll be there. And of course, we'll also be sending out all the slides from all the talks for the delegates of the meeting. Hopefully, you can fill in some evaluations for us to help us with the next meeting, and that'll also mean that you get your CME for attending the meeting.
And we take suggestions. We love putting together the Sick Kids Symposium. It's a real pleasure to have so many people. There's a lot online. There's fewer left with us in the crowd, but there's still a lot of people online. And if you have an idea about something you'd like to hear from Sick Kids Symposium, we'd be happy to see that in your evaluation forms, because I think we love to learn from each other and from you, all of you, through questions and comments, and really look forward to putting on another successful symposium.
Yeah, we would like to thank Sue Morton and all the
Anna Gross.
all the administrative assistant to help us organize this meeting. Thank you so much for your help.
It's Anna, Sue, also.
Find it.
Yeah, here we go. Oops. Because I forget the people from other divisions. Erin Milton is from CBS, and Anuja Jaminda from CCU, as well as Karina Romero from cardiology. So thank you very much to all of them. Okay.
All right. Thank you.
Great weekend.
Thank you. Take care.
Yay. Great. That was great.